Welcome back to The Wellness Effect. In this episode, we continue our discussion around breast cancer, looking specifically at the screening of breast cancer. Head over to our YouTube channel, make sure to subscribe, and hit the notification button so you never miss out on any of our wellness-related topics. Joining me today is Professor Carol Ann Benn, a fellow of the College of Surgeons of South Africa with a special interest in breast disease. She will help us shed more light on the topic. Welcome, Professor Benn.
Hi, just call me Carol.
Thank you. It's good to have you here today.
Yeah, it's good to be here.
I'm really excited about this topic because I think it's a notable issue that a lot of South Africans face. And at what age should men and women go for breast cancer screenings?
So I think the most important thing is to start with this concept of know your norm. Know your body. So don't be scared to test and look. And obviously, as you get older and you lift your top up in front of a mirror, things head south. But it's a concept of if something doesn't feel right, if you've got pain for too long, and breast pain is not really related with breast cancer. If you see something, you lift your arms above your head and your nipple pulls in, know how to examine your breast. And guys and women both have breast tissue. So you feel your breast with the soft of your hand, you use 3 fingers, use your left hand to feel your right breast, your right hand to feel your left breast. I always say feel your breast softly. And the other thing you need to know is when you check for glands, which are your lymph nodes in your armpit, do it with your arm down. When you go for ultrasounds, you lift your arm above your head. So if you feel something that you are worried about, your first point of call is either your clinic or your general practitioner. No one must poo-hoo you and go, nah, there's nothing there. The simplest thing is to do a breast ultrasound. And today we even have things like AI ultrasound where Big Brother is just checking to see what the radiographer is picking up.
Sure.
And we're looking for lumps on ultrasound and we check glands. You can do ultrasounds at any age and they're simple and there's no radiation. You generally start mammograms between 35 and 40. Medical aids start from 50 now. The international guidelines have changed again to 40. Each country has different international guidelines. South Africa doesn't have really guidelines that people follow. So if you've got medical insurance, your insurance may have different access to screening mammograms, and you should have a mammogram with an ultrasound. A screening mammogram is a single view mammogram. In this country, you have both a mammogram and an ultrasound.
Sure.
So it's about health economics. It's follow the numbers.
Okay.
So depending on different countries, how they prioritize health needs is how they will screen different cancers, whether it's prostate cancer in men, breast, stomach, colon, moles. Those are really your big 5 from the cancers that we need to check.
And how often do you need to go for screenings?
So that's really changed. So it used to be every second year from 40 or every second year from 50. And again, it's about health economics. Now what we know is we can screen people differently depending on whether they have a family history, depending on whether their breast tissue is dense. So we really individualize screening depending on what you find. I'm very fussy about people not rushing into biopsies. Needle biopsies around if someone sees something concerning on your mammogram are very expensive. And I always say to people, there's no such thing as an emergency, either when you're diagnosed with cancer or when someone picks up an abnormality on a sonar or a mammogram. So what you need to do is consent is critical in medicine. People need to understand it's their body, not the doctor's. So you don't rush in, you ask. You want a double review on your mammograms and ultrasound. So you've paid for it, you take the disc and you get it reviewed. We have what we call multidisciplinary radiology review meetings. Then consent is about understanding the costs of procedures.
Sure.
And whether your medical aid is funding it or not. I see people who've had multiple biopsies of both breasts to the tune of 22,000 Rand that's not covered by their medical insurance.
Wow.
And that's excluding things such as the pathology when you get the result. So you take time, work out your costs, okay? And then once you have a diagnosis, if they pick up something abnormal, you never rush into surgery.
Okay.
You make sure that you are managed in a comprehensive, multidisciplinary environment, which means it's a bit like there's double check on the doctors. So you don't see a surgeon who goes, let's cut tomorrow. and you don't see an oncologist who goes, let's give you chemo tomorrow. And you're entitled to feedback on all your results and information. That's really important.
Sure.
So I always say it's your body, not the doctor's. Take time, make sure you have a comprehensive understanding. So mistakes that are made are when people rush into biopsies. People think that they must take both their breasts off to treat a cancer. We mentioned a little bit earlier about how cancers start, because it's the wellness show. And I always say 2 things you can do: keep your BMI under 30 and exercise.
Wow.
Those are the strong data on decreasing your cancer risk. Otherwise, you probably can't prevent cancer, but you can decrease your risk. Obviously, eat as healthy as possible. Don't drink and smoke. But what we want is 65% of people who get cancers have no risk factors whatsoever.
Wow.
Yeah. About 25% have family history on father and mother's side. So it's both sides of the family. And it can be a mixture of cancers, from prostate in men, stomach, colon, moles, melanoma, breast, ovarian. Cervical cancer is not related to breast cancer. It's related to HPV, viruses, and everyone should vaccinate. Absolutely everyone, 0 to 100, should vaccinate for HPV. Okay.
And sorry, what is HPV?
A human papillomavirus.
Okay.
And it
Amazing.
causes cervical cancer, and a large proportion of them. And it's all over. So check.
Amazing. And can you maybe explain to us the different types of breast cancer screenings, MRIs, mammograms, and what they do?
So ultrasound, simplest is you use a sonar and you check, no different to when you have a sonar to check if there's a baby.
Sure.
Mammograms are a form of X-ray. Everyone's worried about, don't go for mammograms because of radiation exposure. Actually, there's more radiation exposure on an airplane or in a shopping mall. So you want to go for your mammograms and ultrasound. MRIs are more expensive. I say they're the helicopters, like the Google map, looking from the top. Not everyone needs them. You use them if you've got a cancer diagnosis and complex breast tissue, and if you're high risk. So if you've got a strong family history of breast cancer, particularly young breast cancers. In young women diagnosed with breast cancer, we often use MRIs. But there are all sorts of like funky new things, like elastography, where you check the density of the breast tissue, contrast enhanced mammography, which is you can say a poor man's MRI, but you use a contrast, and you can look quite carefully in terms of what's happening in the breast. So don't get where someone says to you, you need an ultrasound, a mammogram, and they find something. Make sure you have that multidisciplinary discussion before you go in for multiple investigations, because all you're doing is, if you are fortunate enough to have a medical aid, is you are just increasing that cost out of your oncology benefit before you have decisions around your treatment.
I like that you mentioned multidisciplinary.
100%.
Yeah.
100%. Check your mate, check your doctors. If there are lots of them, different pathologists, different radiologists, different oncologists, radiation oncologists, it means, and it must be not a tea party. It mustn't be a case of, I refer to you, you refer to the next person, we all meet together and agree, right? Because we're all referring to one another. Comprehensive multidisciplinary means you have people from different hospital groups, people who don't work together. So in other words, it's looking at what's the best for the patient and not what's best for the doctor.
Sure. And, with the rise of artificial intelligence,
100%.
are there any new technologies that
100%.
are improving early detection?
Absolutely. So we have AI in terms of mammography and ultrasound. So and people are so scared of this concept of artificial intelligence. So it's not replacing the doctors. It's the concept of how and I was telling you earlier, we've got our head of IT presenting in Istanbul on AI, and he was explaining to me it's really using computer logarithms to work out where you're right and where you're wrong, and just fine tune our ability. So it's no difference to working together as a team. All we're using an adjunct of a computer-based information to improve our
I
accuracy
see.
in what we do.
I see.
Yeah,
And have you seen real case studies where those technologies have
100%.
found early
So
detection?
I think particularly in our African environment, what Dom is doing in Istanbul, having virtual multidisciplinary with the use of computer-based learning, means that multidisciplinary team medicine can be available to more people.
Amazing.
Because it mustn't be just urban Johannesburg. It must be, someone should be able to slot in their information, or an oncologist working in the periphery, people who don't have access to medical insurance should be able to pop in that information to ensure best options for treatment. Not everyone needs to rush into surgery. We have a lot of our little old ladies that I saw yesterday who are on primary hormonal blockers, and we're hoping to freeze their cancers. Most people shouldn't have a mastectomy. Small surgeries, breast saving.
Amazing.
Yeah. Less chemotherapy.
Sure.
Really the buzzwords in oncology today are personalized care and de-escalated care. Lesser treatments, personalized to looking at the person, their needs, their healthcare risks, and we take that all into consideration.
I love that you're mentioning that artificial intelligence is actually giving access to those who wouldn't generally have access
100%.
to information and support.
Yeah.
But let's touch on the freezing element. You mentioned that there's
Yes,
new
cryo.
technology. Yeah.
Yeah.
Maybe explain that
So
to
what
us.
happens we do is we take people over the age of 65, and we can, if their cancers are laser, you mentioned earlier different types of breast cancers.
Yes.
So we divide breast cancers into 4 different types.
Okay.
Think of it no different from saying TB, malaria, bacteria, fungus.
Okay.
They're all treated differently. So breast cancers are divided into a group called triple negatives, which have no hormone sensitivity and often need chemotherapies and immunotherapies. HER2 enriched, which have a gene, which is a driver inside the cancer cell, and they all need the HER2 target. And we have different types of those, and they often start with that targeted treatment. And then we have a hormone-sensitive group called luminal A and luminal B, which have different tackies on the cell. That is about the simple ways: are they wearing high heels and walking slowly, or have they got tackies on? And the very lazy cancers, so normal cells divided at a division rate between 2 and 5%, and the lazy ones between 5 and 15%. Those ones in older people, we can give them a hormone block treatment, ultrasound and check that the cancer is melting down, and then we use a technology called cryo, where we put liquid nitrogen into a ball, and through ultrasound technology, and we just freeze the cancers.
Oh, that's incredible. And is this a new form of treatment?
So we've had it in the unit for probably since COVID times.
Amazing.
And in fact, I present on it usually in different parts of the world. And yeah, so it works really effectively.
Amazing.
We've had none of the cancers come back, and there are different things happening all the time. You don't know 10 years from now, we won't even be operating on some types of breast cancer. So I think it's about individualizing care for people, listening to people, and making sure they take time with the decisions. There were some really nice studies that came out around the SARS-CoV-2 pandemic. So our unit is very research orientated. I looked at pre, during, and post-COVID, and we saw no difference between stage, age, and biology. So it means who presented, what age, because people were quick to say, is it a virus, is it a vaccine? It's nothing. We saw the same in our unit in the South African setting. But in a lot of units overseas, they looked at people who had biopsies and couldn't access care. And in some types of cancers for up to 6 months, there was no change in outcome. Now, I'm not advocating that people sit with a cancer and don't do something. What I'm saying is taking a week or 2 to go through your choices, go for different opinions, gives you some form of control in a scenario where you almost feel like you don't have any control. And I think that's really important today.
That's really good.
Yeah.
I've also read up about changing diet and individuals who, instead of going for chemotherapy and the different...
So you can't really do that, because I think diet is hugely important, but I think we mentioned a little bit earlier, how do cancers start? So cells are dividing all the time, and they have little abnormalities in their DNA structure. And this is a really simple explanation, but you need almost 90 cellular changes before the cell goes from the normal cell to the cancer cell. So usually for about the first 10 divisions, your cell repair genes are trying quickly to putty this and fix this and that. And if they can't go, oh, kill that cell. Then after that, it's the little cells in the environment around it. And that's where all the work is being done today. It's called the tumor microenvironment. You have little hyena cells, tumor-infiltrating lymphocyte macrophages. How our immune system works, think when you have a cold and a flu, to kill that cell. And if it can't, then it develops its own plant.
I see.
Once you get to that phase, your diet is not going to manage it on its own, because up to that stage, it hasn't helped. So to ghost and myth bust, okay? You can't say, I'm going to take all sugar out my diet and therefore kill the cancer cell, because every single cell at its base eats sugar. So think of it like a road with a little truck dropping off a sugar for you and a sugar for you. So whether you've got normal houses and normal cells in there, you've got a commune with lots of abnormal, and they have to drop off 10 bags of sugar there. You're not going to be able to starve the cells beforehand to get, the same thing's going to happen. So absolutely diet is important, but diet is mainly important with BMI.
Okay.
And also what you don't want is big highs and lows. So lots of I always say, our bodies are our temple.
Yes.
If you want to drive a Ferrari, put Ferrari fuel into it, okay? Otherwise, if you're going to put really rubbish fuel into it, then it's going to putt along not so well.
That's good.
Okay.
Let's talk about the different stages of breast cancer. Could you maybe explain what that is?
So we have a clinical stage. That's when you examine someone, and we divide it into 4 stages, or simply an early and an advanced stage. And that depends what you feel, how big the lump is, what the presentation is it on the skin, is it involving the skin, is it in the glands? Then we have a radiological phase or stage, when you look and you use your mammograms and your ultrasounds and your MRI if needed, and you work out where the cancer is. Again, early and advanced, and we check to see if there's anything else in your body. Then we have a biological phase or stage. That's when you look at the behavior of the cells, and that's where I spoke about the 4 different types. So stage is important, okay? But we treat mainly on biology, how the cells behave.
Okay.
So in the old days, we used to be stagist. Advanced got chemo and early stage didn't. Then we became ageist. We said young people got chemo and old people didn't. Now we treat on biology, how it behaves. And we treat male breast cancer and female breast cancer identically. And we have about a 1% out of incidence of male breast cancer. Interestingly, Sub-Saharan Africa has a slightly higher percentage, sitting at between 2 and 3%. But I've written and published on, and I'm very interested in male breast cancer and the psychology behind it, because it's a very pink disease, right? And
it's been actually like branded that way.
Absolutely. And then it's difficult for men, and they don't think it can happen to them. Now, breast cancer is not gynecomastia, man boobs. We see lots of man boobs, and that can be related to steroids, overweight, alcohol, marijuana. But male breast cancer, men must check their breasts. And if they've got a single hard nodule or something on the nipple, you come in, we do a biopsy, we work out the diagnosis, and we treat it identically. And they don't need to have horrible ablative mastectomies. You know, when the children draws that pirate scar with the big cuts, you don't need that.
Amazing.
We can do it in ways that we can save nipples, breast save, do it so that it's aesthetically pleasing in men as well.
So speaking on early detection and the new technologies, how does it affect treatment and survival rates?
So that's such a great question. We mentioned earlier about this concept of hostile hospital environments, and what the real push is, know your norm, go for your tests early. It's the wellness show. You know, if you pick something up small and early at an early stage, you've got best option to treat it, and the survival rates can be up to 95% cancer. So I always say it's more dangerous driving in the traffic, living in Johannesburg, being a woman in Africa. So we encourage people to come in. And I am often It's one of my bugbears when people say people don't come in or come with advanced cancers because they're ignorant. People are not ignorant. You know, when you've got a headache, a pimple on your nose, a lump in your breast, people don't come in because the environments are hostile, the costs of healthcare, and they're scared of someone's going to tell them when they come in.
It's true.
So we really, really, I think a good place to end is to tell people, know your norm, check your body, check your breasts, find yourselves a good doctor team, a good ghost busting team. Go for your treatment early, because then you can live a really good life with your cancer treatment. And a big part of cancer treatment today is around survivorship, a word I don't really like because I think we're all surviving every day. But it means that you can go through the treatment changes and take your medicines, no different to a diabetic or a hypertensive, and live a healthy life.
Thank you, Professor Benn, for such an engaging and enriching conversation.
Yeah, absolute pleasure.
Remember to subscribe, and we'll see you next time. BankMed, the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health.